Hello everybody, this is Arthur van Zanten from the Netherlands. I'm the head of ICU and research in Gelderse Vallei Hospital in Ede, the Netherlands, and I'm also a professor at the Division of Nutrition and Health at Wageningen University in the Netherlands. Today I'd like to talk with you on body composition in patients with COVID-19 and whether body composition plays a role in the disease severity. And for this reason, we did a recent study with bioelectric impedance analysis of body composition to find out whether there were differences between ward and ICU patients. It's called the BIAC-19 study. So on this slide, you see my disclosures for 2020. I'm a member of the ISCEM guideline group, as you're all aware of, and I've given lectures for many companies involved in this field, but not involved with companies bringing BI devices to the market. So when we talk about COVID-19, we know that the SARS-CoV-2 pandemic is unprecedented, and I think it's essential to study patient characteristics that predispose to a more severe disease course. And we know that obesity plays a role because many of these patients are obese, have BMIs around 30 or higher. But the problem with BMI is that it doesn't differentiate between tissues affecting an individual's weight or the distribution of fat tissue. And we know that more males are hospitalized with COVID-19 and on the other hand, females have higher fat percentages. So this led to the hypothesis that maybe visceral fat distribution plays a role in the severity of disease of COVID-19. And as you can see depicted in this slide, that males are more commonly apple-shaped persons compared to the females, more the pears. So probably this visceral abdominal fat distribution plays a role in the disease severity and also is associated with leptin levels. So the research question here is body composition associated with the disease severity in hospitalized COVID-19 patients? So we performed this study during the COVID-19 crisis in the Netherlands using bioimpedance analysis equipment to measure body composition, and we included 54 COVID-19 ICU and ward patients. And at present, this paper is submitted for publication. And here you also can see the device and how it works. So what we use the in-body S10 body impedance analyzer, and it's using multi-frequency segmental impedance currents sent through a patient. And you put in the device the height, weight, and sex of the patient. And it can be measured in seated or supine position with reusable electrodes attached to the left and right thumb and index finger and both ankles. And it typically takes only 3 to 5 minutes to measure a patient. And after the measurements, we know the body composition. So we know the fat mass, we know the mineral mass, we know intracellular and extracellular water composition, protein content. So we know the fat-free mass or the lean body mass. That's very important for patients to know because it's associated with the outcome of patients. Also, we get the phase angle, and the phase angle is the relationship between the reactance and the resistance, and it's regarded as a biological marker of cellular health. So in health with a high cell mass volume and robust cell membranes, it causes a delay in signals and thereby a higher phase angle. But ICU patients tend to have a low phase angle, and we know from other papers that it's associated with the outcome of the patients in the ICU, because patients in the ICU have low phase angles. But there is a problem with doing this performance with BI in ICU patients because many of the patients are fluid overloaded, and it will affect the measurements. So iatrogenic over or dehydration will influence the extracellular compartment, leading to over or underestimation of derived BI values. So what we did, normally in healthy persons, there is a ratio of extracellular water to total water that's around 0.38. That's the reference value. So we recalculated all the body components with respect to extracellular water to this reference value, and then we can measure the water overload and readjust all the measured values. So then we get the dry weight. So what I'm going to present is the dry weight of the patient, so corrected for water overloading. And here are the patients. So in total, 54 patients, 30 in the general wards and 24 in the ICU. We did the measurements. And you can see that with respect to the baseline variables of those patients, there is not much difference, except for, of course, that the ICU patients had significantly higher SOFA scores. And also the CK, the creatine kinase levels, were higher in critically ill patients. And all the other variables in the patients were non-significant. In general, the patient had were slightly overweight, and that you can see in this slide. So the average BMI of the group was 29.7, with no difference between ward and ICU patients. There were differences in the days from hospital admission to the BR measurement. So in ward patients, it was only 3 days. In ICU patients, it was 11 days. So in further analysis, we adjusted for this difference in time to measurement day. And as you can see on the measurement day, there was also a higher SOFA score in ICU patients compared to ward patients. And in the lower part of this slide, you see the dry weight BIA values. You can see that the fat-free mass is higher in ICU patients. So more muscle mass, more soft lean mass, and also more total body water, more intracellular water, and more extracellular water. And the skeletal muscle mass index is also higher in ICU patients. The patients are more fluid overload, 1.8 versus 0.9. And the ratio of extracellular water to total body water is also higher in ICU patients. But as I told you before, we corrected for this and readjusted all the BR values based on this standard ratio of 0.38. And also the whole body phase angle levels are much lower, significantly lower in ICU patients. Now, concerning the outcomes of the patients, you can see that the hospital-free days are less in ICU patients. So only 2 hospital-free days on day 28. So an average stay of around 26 days. So ward patients were discharged much earlier. And also there were more complications in ICU patients. So thromboembolic effects, delirium, and other complications. And also the discharge disposition is different. So the ICU patients are less discharged back to their private home and need more rehab facilities or nursing homes at hospital discharge. Now, in multiple regression analysis of dry weight BR values for different outcome variables, you can see that with respect to the outcome ICU admission, there is not any BR value that predicts ICU admission. There is an association with mortality, so fluid overload and having a higher ratio of extracellular to total body water is associated with higher mortality, as is whole body phase angle. So a low phase angle is associated with increased mortality risk. And with respect to other complications, there is no association with body composition. So because of the low numbers of patients, we made a composite score of ICU admission, mortality, and complications. And you can see that not any of the body composition measures, so not the visceral fat distribution, is associated with the risk of this composite score. Only is the whole body phase angle. And also there is no association between BR parameters and vasopressor-free days. So, of course, our study has some limitations, and the sample size is rather small, 54 patients, and the in-hospital mortality was low. Only 8 patients died, a mortality rate of 40.8%. But we tried with the composite score to decrease type 1 error and to obtain a better definition of the disease cause. In total, 43% of our ward patients had limited treatment plans, waiving ICU admission regardless of disease severity. And of course, we did sensitivity testing, but it yielded no different results. Selection bias for ICU admission based on the perceived health or projected survival chances did not strongly influence our main findings. And because of the cross-sectional nature of the BI measurements complicating the inter-individual comparability. So both disease and treatment influence body composition, mainly through the loss of lean body mass and increase of fluid overload in ICU patients and over time. So the difference in time to measurement are important, but we use that in the multivariate regression analysis. So we circumvented this all by using multi-frequency buying device that's less vulnerable to fluid overloading, and we could differentiate between various fluid compartments. And we were able to adjust for the time from hospital admission to the measurement and recalculation of the body composition to dry weight to reduce the effect of lean body mass overestimating by fluid overloading. So if we summarize what we find in this study, that although our cohort was overweight with a BMI of 29, we couldn't find differences in BMI related to the disease severity when we compared like general ward with ICU patient. And we also showed that measuring body composition using BI in COVID-19 patient is feasible during a pandemic. But we found no significant association between the fat mass or the fat distribution or the fat-free mass and severity of illness is reflected by ICU admission, complications, or mortality. Only low face angle increased the odds of morbidity and mortality in COVID-19 patients. So in general, we think we have to do cautious interpretation of BI values in critically ill patients, and we have to correct for fluid overloading. So we have to calculate the dry weight and to adjust all the BI variables for this. BI measurements provide new insights into body composition and face angle beyond classical anthropometric data such as BMI. So we suggest other factors may play a more critical role, for instance, the innate immunity of our patients in the development of severe COVID-19 than body composition. So with respect to the hypothesis that because the overrepresentation of males in the ICU could be due to visceral abdominal fat distribution, we could not find this association with respect to the difference between general ward and ICU patients. So we suggest other factors probably play a more important role. With that, I'd like to conclude and thank you for your attention.